Okay, now I'm going to page 2. So ready once again. In 3, 2, 1. Okay, going to page 3. Okay, so once again, ready in 3, 2, 1. Okay. Okay, so thank you very much, student, and also once again, thank you, Mr. Stanley, for the exciting sharing sessions. So now, without further ado, let us go to the next session. Okay, so next session will be Seeing Well with Diabetes is presented by Professor Dr. Jenny. She's a clinical senior professor from University Tukar Abdul Rahman. So without further ado, let us welcome Professor Dr. Jenny.
Hello, Stanley. Stanley, can you hear me?
Yeah, Prof. Jenny, we can hear you.
So can you see my screen?
Yeah, we can see.
So do you, do I maximize or what?
Yeah, you just maximize and then you open the camera first and then you just maximize. We do.
Um, to open my video, is it?
Yeah.
Okay.
Mm.
All right.
Yep, can see.
Yeah. So, can you maximize for me?
Uh,
No.
no.
I'm not the computer person.
It's on the right bottom there.
Yeah, it should be down.
Yeah, this one.
Now, okay?
Yep, good.
Okay. You can see my cursor
Mm.
as well. Can you see my cursor?
Yeah.
Because later maybe we want to point to some structures to make it clearer for everybody, okay? Yeah.
Okay.
So good morning to everyone. I feel that seeing well with diabetes is a really important um, uh, topic worldwide. It's not only Malaysia, but we need to know that actually all the problems we get in diabetes can be prevented to some extent, not 100%, but um, definitely um very important. So here today, I'm going to present to you Seeing Well with Diabetes. And this is our famous Sungai Long University campus. So what is actually diabetes? And what does it actually do to our bodies or destroy in our bodies? And what does it actually cause in the eyes? Because what it does to our eyes really is very catastrophic because it can ultimately result in blindness. So I hope you all don't mind, but I would like to cover both the very details as well as what are the clinical features. So you bear with me because a very long 1.5 hours given to me, so I've increased my slides, but I will go as fast as I can. So actually it is a microangiopathy involving the retinal precapillary arterioles. This is a little bit of maybe unnecessary, but detailed information. And what actually happens to the structures is that there's microvascular occlusion or blockage, and as well as leakage on the other side. And all these changes, actually you can see in the back of the retina, which is called the fundus. You have intraretinal, preretinal, and vitreal. And what happens is the fundus or the retina is one of the structures in our body where we can actually observe changes in the very, very fine arteries and veins, which have to supply blood to or drain blood from every structure in our body for us to be alive. So the other place that you can observe is in the kidney. So these are two structures that we can see, as well as in the brain. The progressive changes which occur in every structure, the list will include, of course, your cardiac, nervous, renal, ocular, and other body structures. And the ocular effects can be fearful because it causes blindness, and all parts of the eye change for the worse when diabetes, especially, is not controlled. And we know that there are two main types of diabetes: type 1, insulin dependent, and type 2, non insulin dependent, which actually are more prevalent in different age groups. The diabetic retinopathy is higher prevalence at 40% than in the non insulin dependent. And this is the commonest cause of legal blindness between the ages of 20 to 65. Our national figures for prevalence of diabetes by age group, you can see here, occurs in the 55 to the 69 age group, because the peaks are there. WHO data, according to the National Health and Mobility Survey in 2019, shows the prevalence rate of diabetes in adults has increased in Malaysia from 13.4% in 2015 to 18.3% in 2019, with diabetes defined as having sugar levels 7 millimoles per liter. And if you see the national data, 1.7 million are actually at risk. There's an alarming increase in diabetics in Malaysia, of Malaysians with diabetes. Actually, if you look at Malaysia, we are a country of monies, that is very sweet country, full of sweets. Everything we touch almost, kuih kuih and other things is sweet. And we love sweets and we love kuih kuih and so on. So you can see and infer why this graph is on the rise, you know. And Malaysians are fattest in Asia. The adult prevalence of overweight and obesity in some Asian countries, you can see Malaysia tops the list, 45.3%, okay, compared to other countries. Malaysian statistics, according to our NIH morbidity, is that the cross-sectional household survey showed 34,539 respondents who are more than 18 years, the overall prevalence was 11.6. And you can note from here, because we are multiracial, highest prevalence is Malays, who love kuih kuih also, and Malays, highest in Malaysia, the Malays 11.9%, and the Chinese 11.4. I think I made a mistake there, sorry. I think it should be a typo. It should be Indians 11.9 and Chinese the lowest, 11.4, okay? The prevalence known diabetes are 7%, and newly diagnosed diabetics are 4.5. Malaysians love sweets, so I wanted to share with you some local words that we use. In Indians, mitai is sweets, and you get a lot of ladus. Huh? Malays, manis, gula, those are very nice words, kuih kuih. And Chinese is tian tian, or everything that is sweet. The healthcare, we find that in the analysis, 73.5% of patients use government healthcare, and 7.25 only use insulin alone. 45.05% of known diabetics do not ever use eye care facilities or go for eye checkup. And incidentally, they are discovered because they go for an overall checkup. But the sad part is amputees number about 4.3%. What is the risk factor in having diabetes, you know? The risk of 4.3% having to be amputated because they never discover the diabetes in time, or they don't bother to control the diabetes. And that is a sad story. or 3.4% actually suffer stroke events, and 1.6% need hemodialysis and renal replacement therapy. So the risk factors are, after 5 years, approximately 25% of type 1 patients have retinopathy. And after 10 years, almost 60% have retinopathy. That is, the eye structures change, so that they are, in a way, evolving towards blindness. After 15 years, 80% have retinopathy. And so they have vision threatening disease, which is present in approximately 25% of type 1 patients and 15 years duration of the disease. The type 2, you have duration of diabetes of less than 5 years. 40% of those patients take insulin, 24% of them don't take insulin, and duration of the diabetes will be about 19 years, and they have retinopathy and other fatalities in the eye. When you look at the eye, it looks very normal, like yours and mine. You look at this eye and say, it's a beautiful eye. The cornea is clear, the structures all look nice, and the eye looks pinkish, that's all. The eye structure in cross-section, what we are actually examining whenever we say there's retinopathy is actually this is the retina, which is the innermost layer of the eye. The outermost layer is the sclera, and then you have the vascular layer, which is the choroid. And what we are interested in is all the vessels, the fine, minute, micro vessels and so on, are having changes. Okay. The healthy retina will give you a picture which appears like this. And two major regions of the retina. This is the macula, which is avascular, and only the surrounding areas here will have the arterial arcades and the venous arcades. And this is the optic disc, which also can undergo changes. The diabetic retinopathy is a complication of the diabetes, and it leads eventually to blindness. It occurs when the diabetes damages the tiny blood vessels inside the retina, which is actually the light sensitive tissue at the back of the eye, which I just showed you. A healthy retina is necessary for good vision. Diabetic eye disease refers to a group of eye problems that actually people with diabetes may have as a complication of the disease. And all these diseases can eventually cause vision blindness, partial blindness, or complete blindness. There are three main types of diabetic retinopathy. One is the background, which is affecting, you have exudates and so on, which accumulate partly because of high cholesterol as well. You have diabetic, the earliest sign is a small little dilatation of the blood vessels. Oh, sorry, yeah. I lost my cursor, I don't know why. Okay, sorry. These are small areas with new vessels. These are small areas which showed you the yellowish exudates, and in between you have hemorrhages. And these are cotton wool spots, which shows that the retinopathy is serious. And the retinal veins actually appear engorged. And also sometimes you will have a bit of edema, which is confined to the central area of the eye, which is called the macula. But we got good news, and that is laser treatment of the background. That is the background here will result in improvement, reducing the need for the back of the eye to have more oxygen. So as a result, the whole of the retina improves. And this is the good news that we have for diabetics. Laser treatment for more serious retinopathy, where you have new vessels, dilated veins, you have other features as well. And these are laser spots, which are actually the scars which we see at the end of the diabetic treatment. But the most important is that prevention of diabetic retinopathy is very important. And the people who have diabetes should actually see the ophthalmologist for regular eye checkups. We encounter many patients who have had diabetes for 5 years, 10 years, 15 years, and they go to the general practitioner just for medication. But it is the onus, it is upon the general practitioner to advise the patients that they should have an eye checkup. I think every hospital, every general hospital has an eye department in Malaysia. There's no excuse for people to say that, oh, it is too expensive to have an eye checkup. Every hospital has an eye department, and there are screening programs where everybody can have access to for free or for RM1. So you don't have to worry about money in Malaysia for medical checkup, okay? And you can reduce your eye problem by following your doctor's instructions, especially for controlling your blood sugar. And if necessary, your blood pressure. And if necessary, for your high cholesterol. And check your own vision weekly, because sudden catastrophes can happen. You can suddenly have a central venous occlusion, especially if you have not bothered to control your diabetes. And see your ophthalmologist and consult him off and on. Okay, so this is the complication that we want to avoid. And a healthy retina is necessary always for good vision. What are the stages? They are usually mild or moderate or severe. And the early signs are because of leaking of the blood vessels, which you see here, which you will see later in the pictures that I show. There is retina swelling, there are pale deposits, damaged nerve tissue, and many changes to the blood vessels. Mild, you only see microaneurysms. And you can see here, small little round bodies, the microaneurysms which you are actually seeing. And this is because of the changes which are occurring in the retina. You can see the soft exudates, which are here. You can see this when you actually use a special instrument called an ophthalmoscope. You can see the optic disc, you can see the soft disc, you can see actual hemorrhages here and there. Then as the disease progresses, some blood vessels that nourish the retina are blocked. And you can see now the retina looks paler. You can see the dot and blot hemorrhages. You can see soft exudates which are expanding. You can see sheathing along the blood vessels. And severe non-proliferative retinopathy, the blood vessels actually get blocked. And several areas of the retina, they are blocked from their blood supply. New vessels on the optic disc, you can see. Proliferative retinopathy, in advanced stage, the signals sent by the retina for nourishment. Here you can see new vessels. You can see progress in the blood vessels. You can see actual bleeding into the vitreous. These pictures are not to frighten you, but to allow you into having a peep at what actually diabetics have to go through, and to be able to help them to seek medical help earlier, as well as to be proactive if you are yourself a diabetic. And if you have a history of diabetes in the family, to be proactive and make sure and exclude yourself to be one of the diabetics or developing diabetics. Here you can see it's advanced, and the optic disc itself is also very edematous. So proliferative retinopathy, the fibrovascular tissues on the surface of the retina form also membranes, and they are adherent to the vitreous, and they form what are called fibrovascular bands. Diabetes can also produce this. These are the very serious fibrovascular bands that you see, which has caused retinal detachment, and there's actual hemorrhage onto the retina. Then you can see in this already there is pre-retinal hemorrhage. Here again, you're getting hemorrhages. The problem with hemorrhages is they get resolved and they produce these very dense fibrovascular bands which attach to the vitreous and to the retina. And because of traction, they pull the retina away and the patient loses sight. Diabetic maculopathy, you can see in this case, starting maculopathy, but patient has wonderful vision, 6/6, which is normal. So it occurs in 5% of diabetic population. And however, all this bleeding can respond to what is called anti-VEGF. Here in this retina, what is happening is there's a release of a vascular endothelial growth factor from the ischemic retina, meaning the retina is suffering from a lack of oxygen, from a lack of the vessels supplying enough of oxygen. And the changes which occur are all pre-retinal and vitreal. So it's characterized by all the pictures which I showed you just now of neovascular new vessels on the optic disc and elsewhere in the retina, the detachment of and collapse of the vitreous, vitreoretinal fibrovascular bands, vitreous hemorrhage as well. Vision affected by macular exudates. If you see here, this is the center of the retina. This is the optic disc where all our nerve fibers will eventually pass through to go to the brain. And that is how we see. You can see here, there are exudates, plenty of them in different parts around the macula. And the complications of advanced diabetic retinopathy is the hemorrhage, and eventually new vessels form on the iris, because this shows you how advanced it is and how lacking in oxygen the whole eyeball has. And these have to be lasered as well, otherwise they cause bleeding. The diabetic macular edema, however, is the one that commonly causes decreased vision because it is the cells, it affects the cells in the center of your vision. So when you look at a person, you will see the person, but you will maybe have to share with the patient, with the person, that actually you don't see the nose. It's the central vision, because when you look at a face, the center of the face is the nose. So you have to say that actually I don't see your nose. That is maybe one of the things that occasions when you discover actually you've lost your central vision. Okay, and we have very advanced technology thanks to IT. We can even scan the eye and find out the center of the back of the eye is having a bleeding or a cyst. This is the image that we see. So everything else is intact, but this part, either there's blood there or there's a cyst there. So the diagnosis also of the general condition of your diabetes, whether it's controlled or not. HB1AC is very important for long-term follow-up care. And the imaging studies that we have are fluorescein angiography, as well as B-scan ultrasound. So here is a picture to show you how we can see exactly whether the blood is flowing well or not into the blood vessels, into the little eyeball that is your eye. And you can actually see that there is a pre-retinal bleeding here and also here. Can you see? I think you can see quite well. So technology has helped us to diagnose, to be focused, to be able to treat the condition when we use laser therapy. Here, you can see multiple leakages of areas, from the blood vessels. And here, the OCT again shows you exactly whether the retina is healthy or not, or it is swollen, or it is thick. The treatment options for diabetic maculopathy are laser photocoagulation, whether it's grid or Pascal, vitrectomy, and other procedures. The treatment strategies are 90% effective in preventing severe loss if we diagnose them early. And therefore, the onus is upon you as a sufferer of diabetes or a member of the family of the diabetic to opt for early treatment, early diagnosis, and early recovery. So our laser treatment is very modern as well. Photocoagulation is so easily done because of IT technology. The whole thing is programmed, and nowadays you can even observe what we are doing with the um, uh, with the computer, which is supplied together with the machine. And prevention of diabetes means you inform the patient to see the ophthalmologist for an eye checkup. The problems can develop anytime. Eye problems can be reduced if you follow your GP doctor's instructions to control blood sugar and blood pressure. Check your own vision weekly in each eye. It's not difficult. Look in the mirror and just cover one eye. See your ophthalmologist promptly if you notice any change. And macular treatment, we said we can treat it with laser treatment. We use what is called grid or focal laser treatment. And our machines are so computerized and so tech high that we can actually program how the laser spots should be done. And this is beautifully done when we program on the Pascal machine. This is the grid pattern for macular edema. There's swelling in the center of the eye, and this will save the eye. All the blood vessels will be more or less closed, and the central area, the edema will subside because there's reabsorption by the other vessels around it. And eventually the patient will be able to see quite well. How is it treated? So most important and high on the list will be people with diabetes should see that the levels of blood sugar, blood pressure, blood cholesterol should all be optimized and treated properly. During the first 3 stages of diabetic retinopathy, we can do selective treatment with laser if it's necessary. And the main goal is to prevent retinopathy. Therefore, there must be tight glycemic control associated with reduction in development of retinopathy, and good metabolic control and proper management of hypertension to prevent progression of diabetes. And we do focal laser with the use of the fluorescein angiogram pictures, which is actually an X-ray of the back of the eye after we inject a dye called fluorescein. And then we can actually focus on the exact spots where we need to laser. Then if there's actual hemorrhage, we can inject intravitreally triamcinolone, which is a steroid, or anti-VEGF drugs, which will enable the reversal of the retinopathy. So all these are just to show how we can make use of the advances in IT for all these procedures. And diabetic retinopathy, actually, if you see in summary, there is a staging. You can see in very early until the late stages where you have all the complications. And selective treatment we can do on the periphery, what is called retinal photocoagulation. For this type of retina, which is really at the end stage, already the retina is detached. The retinal surgeons can even flatten this retina, but the onus is on the patient to keep his diabetes under control, because all this good work, all this treatment, all these big mega payments, you can say, that have to be involved will come to nothing if the patient does not maintain the blood sugar level and be able to see at least partially. Of course, these two patients more or less have lost their vision, and even the best surgery by the retinal surgeon will not really put everything back into shape. This is also vitreous hemorrhage and traction detachment. Advanced diabetic retinopathy. And these we can still salvage, give intravitreal VEGF for this type of case and this type of case, and the whole hemorrhage will reverse. Neovascularization will reverse. Many things will reverse together with pan photocoagulation again. But again, as I keep repeating, prevention is better than cure. Vitrectomy can be done. These are the areas that the surgeon will do. Corticosteroid therapy, which I mentioned to you, triamcinolone, anti-VEGF therapy, and this may have to be repeated, but it is a very expensive drug. It costs about 3,000 in Malaysia just for one injection. But still, there is hope if the patient comes early. Many reports of reducing macular edema definitely, and it can be used in combination with laser therapy. These systemic conditions are more important: adequate blood glucose control, conventional versus intensive therapy, the control of your blood pressure, the monitor of the hemoglobin HB1AC, dyslipidemia or controlling the cholesterol, and monitor the renal function. Because inevitably, what you see in the retina reflects what is happening in the kidney. And quite a number of patients will simultaneously be experiencing a slow decay in their kidneys. So they eventually have to go on hemodialysis, which is serious then. So the reminder to each patient is, if you have diabetes, get a comprehensive dilated eye exam at least once a year. And your eye doctor can tell if you have macular edema or any stage of diabetic retinopathy. Whether or not you have symptoms, detection and timely treatment can prevent your vision loss and prevent permanent blindness. Prevent blindness from diabetic retinopathy. And the sweet killer I want to share with you is rising sugar intake causes more deaths. And all these are in the STAR and so on. You know, diabetes threat is bigger than any other thing. The other systems affected are the kidneys, nephropathy. Your brain will get neuropathy. You can get vascular myoinfarcts in the brain itself, microinfarcts, sorry. And you can get the development of slow dementia, unnecessarily started because you have diabetes and not have it controlled. The heart itself, you can have cardiac complications. So the treatment involves dieting, correct food balance, 10 exercises and diet for controlling diabetes. It depends what the slim miss sitting here depicts to you. So you have to slim down. And exercise to lose fat. Diabetes, diet, and lifestyle plans are very important in the control of diabetes and prevention of cataracts and retinopathies, and for you to be able to see well in diabetes. So I want you to take home this message. The prevention of diabetes is better than cure. And Happy New Year to all in China and Malaysia and elsewhere. Forgot in Singapore as well. Thank you. That's all, Kenneth.
Yep. So thank you, Prof. Jenny. For student, do you have any question that you want to ask Prof. Jenny?
Yeah. I have 4 questions. If they don't ask me the questions first, I will ask them.
So student, if you have any question, you can type in the chat box.
Shall I ask the questions first, Kenneth?
Maybe later there's one question in the chat box.
Oh, you have, okay.
Yeah. They say,
Fire.
is there any? Yeah. It asks, is there any difference between the method of is there any difference between the method of prognosis of type 1 diabetes and type 2 diabetes in eye treatment?
Is there any difference?
Yeah, between the method of prognosis of type 1 diabetes and type 2 diabetes in eye treatment?
The prognosis in type 1, which is insulin dependent, is bad. I can tell you the story of BAD, and I can relate to you um, uh, several cases, but I want to just relate one specific patient. This patient, to show you how the prognosis is and how serious it can be in type 1. The majority of older people have type 2. So the type 1, this particular young man came to the eye clinic. He was 30, no, he was just about 30 years old. And both his eyes had advanced retinopathy. One eye had vitreous hemorrhage. He had only hand movement. That means when you put your hand in front of his right eye, say, then he can see the hand. Otherwise, if you give him the usual visual chart, he can't see anything. All right. And then, uh, Kenneth, you shocked me by putting my picture there. Lah. Put the screen picture, Kenneth.
Oh, okay, okay.
I don't want to see myself answering the question.
Oh, okay, can.
In minimized form, okay lah. Okay, yeah. So, um, where was I? Yeah. So, this young man of 30. Why is there an echo?
Maybe the line is not well. Yeah.
Oh, okay. Then you put it back. Sorry lah.
Oh, never mind. We can hear now.
I can. Yeah. So, this young man, see the echo. So this young man was working in the hospital as a supervisor for all the cleaners cleaning the toilets. His father was the owner of the company. And do you know that he's a graduate in management? But because of his visual handicap, he was unable to work in an office. And anyway, uh, he had diabetes from the age of 16. He has been on insulin all these years, and he has not been consistent with his treatment, and that is why his eye complications were very bad. He went to the Layang Hospital, the Center for Retinal Detachment Treatment and so on. But his retina could not be salvaged. He could not be restored to normal vision. But in his case, because he's still young as well, I referred him to the Malaysian Association for the Blind. And what happened?
Oh, I just stopped share. It's okay. You can continue.
Can I be heard?
Yeah, can.
Okay. So I referred him to the Malaysian Association for the Blind. I'm sharing this story because we have a cross-section of listeners. You all may be having diabetic relatives and so on. That even though they become blind, there is still hope for them, because in the Malaysian Association for the Blind, there is a section where we rehabilitate, visual rehabilitation of the patients. So they can be referred to because this is an educated person. So I referred him there to learn computer braille. You know, when the person is blind, they teach them braille when they are growing up in the St. Nicholas School for the Blind and so on in Penang. Here, they actually teach grown-ups so that they are able to make use of their prior computer knowledge to actually use new computers which have actually got braille dots. You know that these patients actually have the braille dots so that they can know A, B, C, what is the letter, and so on. So he went there for that course, and we could help him in that way. But I'm just showing you, whoever asked the question, how serious uh, insulin dependent diabetes, how serious the complications are, and therefore you must be vigilant and take the timings. You have so much advanced technology. You can even use clocks which have timers to help them to remember. You have so many gadgets that you can help your patient with. So whoever it is, I think this is one answer. For the majority of diabetics, they are not insulin dependent, but they take oral drugs. They are either on glucophage, metformin, or whatever. But still, they will not conform, because I think for many people, regularly having to take medication is very tedious. So they do not want to go on taking. So you have to encourage them to do exercise. A simple exercise on a static bicycle is more than enough. Just 50 cycles a day, huh, will slim the person down, will keep the whatever they consume, the sugar down. And also in dieting, you can advise them, take small meals and don't eat massive amounts of rice all at one time. Take small meals. You know, I have many non-insulin dependent, but taking oral drugs. Taxi drivers, for instance, they come with complaints that after they eat their dinner, because I think that's the end of the day, they eat a lot of rice, they suddenly become short-sighted. They take the taxi out and they cannot see. Everything appears to be not so clear. So I explained to them that I asked them, how do they eat their food? And inevitably, the story that because at the end of the day, they love to eat more rice and so on, you know. And then also because when you drive at night, it's darker outside, they suddenly realize they cannot see many things around them. Even the signboards have disappeared. So you have to advise them how to diet, to take smaller meals, and so on. So prognosis definitely is better for them. They are, we have seen patients 5 years, 10 years after detecting diabetes, the retina is clear. But you have to send them regularly, maybe for screening in the hospital clinics. Many of our hospitals now have screening clinics. They even have fundus cameras, which will take photos for them as a record. So we have highly efficient services available for our patients. And we even have dietitians who are trained to advise them and to counsel them how to eat well. So I hope that answers the question, Kenneth.
Okay. There's another one more question, which is diabetes mellitus is a common chronic and non-communicable disease in China. However, it can lead to a quantities of serious and irreversible disease such as diabetes nephropathy, diabetes eye complication, diabetes foot, and so on. Except the diabetes with eye problem, what are we supposed to do to prevent the diabetes from others complication?
I don't, what is the focus of the question? On
Mm,
the eyes only? Because he's asking the question in a very roundabout way. What is the
yeah.
focus of the question? Is it he
Uh,
wants to know about the eyes?
Except the diabetes with eyes problem, what are we supposed to do to prevent the diabetes from other complications?
Or from nephropathy, from the gangrene of the feet and so on? From having to have the legs amputated because of uncontrollable diabetes and gangrene, right?
Hmm.
Is that the question? How are we to prevent the other things? Because we are today stressing on how to prevent complications in the eye, right? Am I right, Kenneth?
Yeah.
Is that what the person is asking?
Yes.
Ah, I already enumerated just now, actually. Uh, to prevent overall, it is to stabilize the diabetic control. That is the most important thing. So a visit to the physician, if You complain that the fees to the doctor is very expensive. In Malaysia, especially, I think in China it will be the same. We are able to supply a lot of medications free to patients, for diabetics especially. If their drugs are very expensive, still our hospitals are giving FOC. There should be no complaint. And they should be stabilizing, making sure they take the medications properly, go regularly for the checkups, and eat well. Not just eat anything that is placed before you. Eat well means maybe some meals you have to skip, or sometimes you have to fast from certain foods, fast from sweets. Especially in Malaysia, everywhere you go you can buy very cheap sweets, isn't it? And they are really delicious. I also enjoy them very much, but we also must do activities which will help to improve our health, our general health. uh, because every fat person is eligible to have diabetes. I'm using the word purposely, eligible to have diabetes. Huh? So uh, the prevention and the control of the sugar is very essential for prevention of the other complications as well. You can have the hypertension being accentuated because you also have diabetes, and you have a higher chance of loss of vision from central vein occlusion in the eye, or central arterial occlusions in the eye, when you have a combination of high blood pressure not controlled and diabetes not controlled. That is very bad. Yeah. So I think the regular visit to the doctor and an eye checkup, and usually the GPs, I think, or even the doctors in the hospital will make sure you get your urea, the urine analysis, the urea levels also tested to see whether your kidneys are functioning properly, and regular BP checkup, HB1AC. All these are very, very essential. I'm not sure that answers the question in total. Kenneth?
Hmm. Um,
Is
I
the
think
person satisfied with the answer?
I think yes, the student is satisfied with the answer.
Okay.
Hmm.
Thank you.
Okay, there's another one more question. It says that diabetes and hypertension often exist together. So is retinopathy caused by diabetes also related to hypertension, and which may be the bigger one?
Which may be what?
The bigger one.
It varies from patient to patient, but they can coexist. And typically, hypertensive retinopathy will present not with all these complications in the retina. Typically, it will be uh, the typical sign is they have flame-shaped hemorrhages, which are very typical of uncontrolled hypertension or high blood pressure. So um, it is they can coexist, but you see what happens in diabetic is to do with your diet and also your inheritance to some extent. Hypertension also is also similar, and uh, these can coexist definitely in the person who is already uh, having a risk, your age, the way you eat. And hypertensive retinopathy, uh, also other medications which you take for other sicknesses, say painkillers. Voltaren is one of them. Their side effect is to produce hypertension. Clarinase, which is a drug that we take, it is called epinephrine. It increases the heart rate, is a side effect, and it also increases the blood pressure. So having medications for other sicknesses that you have also can produce hypertension as well. So you have to be very careful. You know, once you go beyond 40 and 50, we have to be a little bit more careful than when we were young. You know, once you reach 40, we are middle aged, and things catch up with us, whether we like it or not, right? When we reach 60, our joints have osteoarthritis, whether we like it or not. Uh, it is to prevent them from becoming serious. Uh, so after 40, 60, we have to live a bit more carefully. Okay, Kenneth.
I think it's okay.
Yeah. Can I ask some questions instead?
There's another one more question.
Oh, yes. Okay.
Okay, so how to reduce our appetite for sweet food? It's so delicious and many food has sugar, like fruit and beverage. Okay, and when I was drinking some sweet beverage, my grandpa showed strong eager to drink too. Okay, this is not a question.
No, no, no. This is habits,
Oh,
isn't it? This is habits, because I'm sure everybody who's listening to me, and you, Kenneth, and I also love sweets. You cannot deny that. And Chinese New Year is around the corner. We're going to have plenty of sweets. And even our bapo, you know, the roast meat, bapo, is also sweetened. Everything is sweetened around us. And you wish each other also, but you then never say happy and sweet New Year. That's all, isn't it? But everything we take is sweet. So I think it is a matter of, you know, that we human beings have psychologically, we have the ego, we have the super ego, and we've got the id. And when we given, if we given to sweets, usually we are satisfying our id, isn't it? There is no, um, uh, after all, eating is not wrong. Eating is part of life, right? And so I think it's a matter of self-control. Um, you have to make a super ego decision. In other words, tell yourself that this is not 100% good for you, and it can be toxic. Just now I showed, isn't it, sugar killer? Did you remember that PowerPoint slide I showed? Um, Share screen. Can I share screen, Kenneth? Kenneth,
yeah, you can share now.
I can share.
You can share.
Click on the green one. Share screen.
Yep.
Go back. Oh, it should be this one, isn't it? Just behind this. I think I go back. Can I go back?
Okay, you can press the backward button on the keyboard.
Yeah, I'm pressing, but it's not going. Can you shift it for me to the
Uh,
sugar killer? Is, I think, maybe 3 or 4 slides back, earlier to this.
um,
Are you able to
I
shift it? No. Hmm?
um, I send a request to you. Can you see a request?
Approve,
Yeah,
is it?
approve.
Okay. Now you do. I cannot shift it. One more.
One more.
One
This
more.
one?
Some more. This one, sweet killer. Do you remember this picture? Sugar is not good for you. Rising sugar intake causes more deaths. Uh, Diabetes facts worldwide. You can read the details for yourself. And diabetics, the threat is bigger. Sugar more harmful than drugs. Consumer Association of Malaysia. So uh, every time you see temptation, I don't think you really give in to temptation, right? So I want to refer back to Stan Lee's say, he was giving an example of, oh, you see a girl you like, so you have to think what are her habits and things like that. So you have to make a mental effort, isn't it, there, to think twice before you want to approach the girl, right? So I think those of you who have a weakness for sugar, look at this sweet killer and remember this picture and think twice before you overeat it lah. You, I, I think there's really nothing wrong, but my husband is a diabetic, and I always tell him, you can eat as much as you want, doesn't matter, but you have to get it off your body, right? So you have to exercise. Go to the next slide, Sandy. No, sorry, Kenneth. Next slide.
Slide.
Next.
Oh,
This one.
this
No,
one.
no, no. Stay there. Stay there. Treatment involves dieting, so you have to have the balance. Exercise and diet for controlling diabetes. So I uh, would not agree with you giving in to the sweets temptation. You have to think twice. You can eat as much as you want, but I think you have to get it off your body, like you have to exercise. Instead of asking somebody to do an errand for you or drive to the nearest shop, you walk up to the nearest shop, for example. That won't be very exciting for some of you. Huh? Okay, any other questions?
Hold on. See the chat. I think no more. Maybe you can ask student some. Yeah, there's one student, Chen Ying. You raise your hand. Can I know? Is it you want to ask some question? You can unmute yourself. I think no more question from student. Maybe you can ask student some question, Prof. Jenny.
You go down, you scroll down to the last slide. Go down.
Hold on. I send the request again.
Oh, have to send. Can
No,
I
no, no.
move this? Can I
Uh,
move this? Oh, I can. I can. I
hmm.
got back control already. Uh, so I decline. I will just go down. Yeah. Now, okay, Chris. Complications of diabetes. Anybody want to answer?
Yep, maybe student can type in the chat box.
Chat box.
Yeah.
Okay. Somebody answered, is it?
Not yet.
Yeah. No. Can they say unmute? Unmute and just speak. Can they
Can they can unmute?
ask them to unmute and speak? I want to hear them. Then I can talk to them and explain.
Maybe student can unmute themselves.
Anybody want to say? Doesn't matter if you're wrong.
There's a two answer in the chat box. The first one is nephropathy. The second one is blindness.
Oh, both wrong. What is this picture? What is this structure here? No medical students are in the audience or anybody who has seen their grandpa or grandma's eye. Huh? What is this? What is this? I was going to tell Kenneth that this is a $10 question. You have to send money to the student. Nobody?
Is it
Three?
cataract?
Who's that?
Ying Han here.
Who's that?
Ying Han.
You?
Ying Han.
Inhan, you're a medical student, Inhan.
Yeah.
Oh, which year?
Year 2.
Very good. Anyway, you give your email to Mr. Kenneth, or you can send to my address and with your bank account, and I give you back $10. Okay. So this is a cataract. You can see that there is a whitish. If you look at each other's eye, you will not see this whitish structure here in the center of your eye. This is a dilated pupil, means we have use a drug to make this open up big so that you can see this structure in the center. And this structure is your lens, which has aged, which has changed, but diabetics get these cataracts earlier than others. So this is a complication of diabetes. The normal age for getting is above 60 something, but diabetics can get it, say at 40 something as well. So they can get it early, and this causes them blindness. Okay, next slide. Where did my question two go? Disappeared. Oh, here. Okay. So, Ingan, you cannot answer already. Any
Yes.
students here? I showed this slide earlier. Anybody want to answer? Even non-medical people can answer, I think, by now, after my little tutorial. Anybody want to say?
Diabetic retinopathy.
Who is that? Correct. Diabetic retinopathy. Who is that? You got the dilated vessels. You got the constricted arteries, which can indicate hypertensive retinopathy. You got new vessels, which are all over. You have exudates here, which you can see, right? Could also indicate the exudates could also indicate there is high cholesterol as well. Okay, who answered just now?
Hi, Prof. Jenny. It's Kathleen.
Oh, Kathleen, okay. Anyway, you all haven't. So you also take my email and this one and give me your bank account. I will put in $10 for you. Okay, next one. Actually, it's all written the answers here. So I shouldn't quiz you already lah. Just revision only how the stages are. And this one? Okay. Who would like to answer? Third person? No more medical students? Actually, the answer is given here, pan photocoagulation, but it's indicated by all the white spots. This is what the AI technology produces. High, fine and refined technology, because the laser spots, you can program them to whatever size you want. And this is pan-retinal photocoagulation, which will cause all these bleeding areas to regress. And it will be paler and improve. And the edema, which is here, will improve, and patient will be able to see again. Okay, that's all, Kenneth. That's the end. Thank you.
Yeah, so student, do you still have any other question you wanted to ask Prof. Jenny?
Other questions, yeah.
If no more question, then maybe I will end this session. So thank you very much for Prof. Jenny for the exciting sharing sessions. So I believe our students have learned a lot from you. Okay. So once again, thank you very much. And also thank you students who participate in this session. So now will be the group photo session. So all students, please kindly turn on the camera for the group photo session. Okay. Okay, so ready? Can you all give me a thumbs up? Okay, ready in 3, 2, 1. Okay, give me a minute. Okay, you're going to page 2. So ready once again in 3, 2, 1. Okay. We are going to page 3. So once again in 3, 2, 1. Okay. Okay, done. Okay, so thank you very much to Prof. Jenny.
Thank you to everybody for listening.
Okay, thank you, Prof. Jenny, and also thank you, students who participate in this session. So now will be a short break and come back on 2 p.m. Okay, so student, you can go for a short break and toilet break and come back on 2 p.m., which is Professor Huzen. His title will be Introduction of Traditional Chinese Medicine. Okay, so thank you everyone and see you all later.
Kenneth,
Yes.
I attend this event to TCM.
Oh, yeah, can.
So later, so I zoom out first. Is it?
Uh,
Or leave things, leave it as it is.
you can stay also can. You can leave and come back later also can.
I just stop video.
Mm.
And
Okay, so thank you very much to students.
huh?
Yeah. Yes.
Kenneth, I can keep everything like this. I
Yeah.
just mute and video recording stop. That's all, right?
Yeah.
2 o'clock, I can just come back to here and can listen, right?
Yes.
Thank you.
Okay, no problem.
You ask those 2 students to send in to me. Give them my email.
Okay, can.
Then I can bank in $10 for them.
Okay.
Okay, yeah.
Okay. Thank you, Prof. Jenny. Okay, so thank you to all the